Welcome to the podcast on assessment and management of older adults with complex illness in the critical care unit. This podcast was created by Melissa Aslagi from the University of North Carolina at Wilmington School of Nursing, and it will be presented today with Dr. Mary Beth Happ. It's based on content co-authored by Dr. Mary Beth Happ, Dr. Michelle Ballas, and Dr. Colleen Casey. We'll begin by letting Dr. Happ introduce herself.
I am a critical care nurse researcher as well as a geriatric specialist. So my concern has been, both in research and my clinical practice, older adults and the unique problems that they encounter during serious critical illness.
So the purpose of this module is to prepare baccalaureate nursing students for some of the challenges experienced when caring for critically ill older adults. So Dr. Happ?
Older adults make up about 55% of the patient days in the critical care area. The most common diagnosis for older adults are acute respiratory failure and or sepsis. However, those diagnoses can be in combination with other acute illnesses and injuries and surgeries. What we know about older adults, and I think what is most important for students to understand, is that chronologic age alone is not a good predictor of poor outcomes after critical illness. So we can't assume that because a person is in their 80s or 90s that they won't do well after a critical illness. There's wide variability in outcomes following an ICU stay, regardless of age. And some of the most important predictors of outcomes are functional status before illness. So those people who were living in the community and doing well before a serious critical illness are likely to do well afterward, provided that we can prevent complications that might occur and that older adults are susceptible to in the critical illness phase.
What do nursing students need to be most aware of and looking for in this patient population?
Well, certainly they need to be aware of what special risk factors go along with the aging process and what risk factors patients now carry with them after they've had a critical illness. Understanding that we need to be mindful of things like acute confusion for older adults once they've experienced a critical illness, functional declines, and weakness, muscle weakness after a critical illness. We want to be particularly attentive to history taking and comprehensive assessment, and for students to understand age-related changes in all the body systems to really be able to tailor both their assessment and their understanding of what's going on with a critically ill older adult based on age and physiology. One of the most important areas, I believe, and this is probably my bias, in the assessment is neurocognitive and behavioral assessment. And so managing the neurologic and thinking areas during critical illness can be crucial. Both history taking, what is their past pattern, what kind of behaviors and thinking skills did they have before they got sick, and really putting together astute assessment about, this is delirium because it's a fluctuating course. They didn't have it before. The main problem is attention and focus. So not assuming certain characteristics just because they're old.
And so if you are dealing with an older adult with an acute confusion, what are some, obviously you can't ask that person their history. Okay.
Comprehensive assessment of a critically ill older adult's pre-admission health status and functional ability really help identify their risk for what we call cascade iatrogenesis. Iatrogenesis is a problem that occurs during hospitalization, kind of as a result of hospitalization. And in older adults, we talk about a cascade of problems occurring as a result of hospitalization, that one thing can lead to another, that immobility can lead to skin integrity compromise, as well as a decrease in oxygenation, and then susceptibility to nosocomial infection, and so it can all be a cascade that we would want to prevent. In addition, this cascade can lead to truly life-threatening conditions. A pneumonia that's hospital-acquired can be life-threatening to older adults. So this slide is from a classic article published in 1993 in the Annals of Internal Medicine, and the author is Dr. Creditor. It's important in that it follows some of the usual differences in the body in aging, such as a decrease in muscle strength and aerobic capacity, vasomotor instability, lower bone density, lesser ventilation capacity, and then shows how bed rest and immobilization that occur during hospitalization, and certainly during a hospital stay in an ICU, can then lead to other conditions that lead to real decrements in a person's function and health status.
So this really actually kind of shows that cascade that you were talking
It
about.
does.
Where
And we'll just take one, and that is a decrease in bone density. So naturally, during the aging process, we know that there's a decrease in bone density. But once a person is immobile, bone loss is accelerated. This also can lead to a shift in electrolytes during bone loss, and we can see a greater risk for fracture and fall once we do start to mobilize the patient. Creditor assumed, if you look at the very bottom of the model, that these complications or endpoints of the hazards of hospitalization lead to nursing home placement. And that's certainly kind of the worst case scenario for the patient who loses function and independence. But we could also look at other outcomes as well. It's really important for us to obtain information from either the patient, their relatives, or other caregivers. And that may mean picking up the phone and calling family, or if a patient is admitted from a long-term care facility or some kind of a institution, to find out what they were like before their critical illness and critical care hospitalization in terms of their memory, executive function, meaning how was their problem solving and their ability to write a check, read a book, do a crossword puzzle, their overall functional ability in daily living. Did they do the grocery shopping? Was this a person who played golf right up until the time that they had an acute event that led to an emergency room visit and ultimately an ICU admission? Also very helpful to know about their emotional state and coping strategies. Was this a person who was prone to depression, who was maybe on medications for anxiety and depression prior to hospitalization? This will help us understand their emotional responses and perhaps behaviors during critical illness. So again, instead of assuming that when a person might appear a little anxious or agitated that they aren't delirious but have some anxiety and emotional issues that we'd like to talk them through during critical illness. Also very important to ask about the patient's behavior, typically how they interact with others, how responsive they are, and how were they able to communicate before critical illness. Often in the ICU, a patient's unable to communicate because of respiratory tract intubation, either an oral endotracheal tube or a tracheostomy or a external ventilation device like BiPAP. So we want to know what their level of communication ability was before hospitalization so we can best help them to communicate around the tubes and other impediments to communication. Another very important aspect of the assessment on admission to the ICU is obtaining a list of all of their prescription and non-prescription medications, including herbs and supplements. We want nurses and student nurses to be alert for non-specific presentation of adverse drug reactions and really to be concerned about potential withdrawal syndromes. An example of a potential withdrawal syndrome that we haven't been alert enough to in critical care is withdrawal from antidepressants. So many medications for depression or migraines carry with them very serious and uncomfortable withdrawal syndromes, headaches, nausea, vomiting, anxiety, tremors, which in the context of the ICU we might interpret as agitation and medicate in a way, sedate for, instead of looking for ways to actually continue their previous medication and avoid these very uncomfortable and in some cases dangerous syndromes. While we don't have enough time today to go into every system of the body, I'd like to give you a couple examples of body systems that understanding the assessment will help you understand what to expect in terms of their function in the ICU. So we know that age affects renal function. Certainly it affects different people to a different extent. So you can't make assumptions that because I'm 60, I'm going to have a particular value assigned to my creatinine clearance. But in general, we can estimate that creatinine clearance, for instance, for a man who weighs 72 kilograms, will change over time. So for someone who has a creatinine of 1 milligram per deciliter, at 30 years of age, their clearance will be 110 milliliters per minute. At 50 years of age, that decreases to 90 milliliters per minute. And at 80 years of age, on average, that result is 60 milliliters per minute. And so what that means is not only can they not process fluids as quickly, but their drug clearance for drugs that are metabolized renally slow significantly. After thinking about renal function, I think the most important system to consider and the reason that people end up in the ICU is for respiratory support. Respiratory and cardiovascular support are kind of the two main reasons that people are in ICU, that and for close monitoring by nurses. So what do we know about age-related changes in the respiratory system? We see progressive decreases in the strength of respiratory muscles, in lung elasticity, chest wall compliance, and oxygenation level. Ventilatory responses to hypoxia and hypercapnia change during aging. And we know that the number and efficiency of cilia in the airway are decreased. What that results in is a greater risk of respiratory tract infection and reduced ventilatory capacity. So adjustments in assisted breathing in ventilatory settings are likely to be necessary for the older adult. What can nurses do? Certainly those interventions that are classic, such as coughing and deep breathing, the use of incentive spirometry, and non-invasive positive pressure ventilatory strategies are important. The other important nursing interventions that sometimes get lost are early and frequent mobilization. This is a tough thing, but research, and very recent research, is confirming that this is one of the single most important things that you can do in the ICU to improve outcomes. That means really partnering with physical therapy for ambulation, mobility, and conditioning, even if in the very early stages of critical illness, that just means passive range of motion and some upper extremity exercises. We know that ventilatory improvements can be directly related to improvements in upper arm muscle strength, upper extremity muscle strength, and certainly even greater gains once we get people up and ambulating. Proper oral hygiene is important to prevent ventilator-associated pneumonia and aspiration pneumonias, and pain control is necessary for people to take good, deep breaths and be comfortable enough. The other great risk for older adults is prolonged mechanical ventilation. And here is the place, kind of the turning point in a critical illness where we see age being the big risk factor. Is more likely in the older adult and is associated with high rates of morbidity and mortality. So patients are more likely to die in the hospital or within 12 months of the acute care hospitalization. They're more likely, if they survive the ICU experience, to have a prolonged stay in an extended care facility, either a long-term acute care or nursing home or rehab facility. They're at increased risk for readmission to the hospital and for continued floor function and impairment. Older adults often arrive at emergency departments or in the intensive care unit with acute neurologic symptoms, with mental status changes. And mental status changes may be the atypical presentation for sepsis, for an acute infection, or for some other injury, for perhaps a head injury after a fall or a stroke. So neurologic symptoms are kind of the window into a variety of problems that are harbingers of critical illness. So we want to understand changes in level of consciousness or cognition for patients and try to sort out in that very good history taking what some of the causes might be. Looking at electrolytes first off, potential for drug toxicities, understanding what medications they've taken at home and how they've taken them. Have they doubled up? So here's where that thorough history taking an exam as well as follow-up testing becomes important. What we know about age-related changes to the neurologic system are that when coupled with acute pathology and the ICU environment, patients are at risk for cognitive dysfunction, either post-operatively or during some other kind of acute illness. Patients who are older are at greater risk for falls and for physical restraint use. In other words, the response often to an altered mental state during hospitalization is a protective kind of response that involves the use of physical restraints. And our message today is that physical restraint use can be particularly harmful to older adults, and so that nurses should make every effort to minimize and restrict and find alternatives to physical restraint use. We're very concerned about the judicious use of sedation, and this is a tricky balance in the ICU. We know that Oversedation is particularly problematic and is easy to do for older adults who require lower doses of sedation. And we know that sedation is the primary offender for leading to delirium. And what I'd like nursing students to be most aware of is that delirium is one of the most commonly encountered disorders in the hospitalized older adult. That we know that up to 70% of older adults admitted to a medical ICU experience at least one episode of delirium during their hospital stay, and that any episode of delirium can be associated with unfavorable short and long-term outcomes. And the more days spent in delirium, the more problematic their recovery can be. Delirium increases hospital length of stay and predisposes patients to other complications. First, we want to prevent, and secondly, treat. And in preventing, we have to continually assess the patients for delirium because it has a fluctuating course. And so in our morning assessment, we may find that the patient is fine, but by afternoon is testing positive for delirium. I like the confusion assessment method for the ICU, or the CAM ICU. It's used often in conjunction with the Richmond Agitation and Sedation Scale, and students will have access to those scales through the Try This series on Hartford's website. And the confusion assessment method is helpful in that patients can use yes-no answers or head nods. It doesn't involve any verbal response. Maximizing the older adult's ability to communicate and to interact is an important way to improve their cognitive function and thinking. And so we advocate providing alternative means of communication to patients. That is pen and paper, having the nurse use gesture, as well as encouraging patients to use gesture to communicate, and having access to picture, letter, or word boards. We promote having glasses and hearing aids available for patients, marking them clearly, and not sending them home with family, as people have done in the past. Facing the patient when speaking to them, it's important for the patients to be able to receive and understand your message, just as it's important for you to be able to understand and interpret their message without speech. So getting the patient's attention before talking, speaking clearly and loud enough, although not shouting, for them to understand, and very importantly, allowing some pause or wait time. If you can imagine not being able to speak suddenly because you have a tube in your mouth, you have to think a minute about how to get your message across around this impairment. And so we have to allow them that extra moment or two to kind of compose. We recommend allowing at least 5 seconds. And that's longer than you think. You might have to count through it to slow yourself down. We know that the more that you take care of a patient who is non-speaking, the better you get with that particular individual at understanding them. So we promote consistent nurse-patient assignments so that you can become better at understanding. Families are a good resource for communication, although they may have never experienced this patient as non-speaking either. So we kind of have to work together, I think, to interpret a patient's cues. We use visual clues and gestures, actually writing choices for the patients with bullets. Another technique is using tagged yes-no questions. So yes-no questions are really common in the ICU. The nurse often controls the communication, and patients may only be able to nod their head. But if a person is having some cloudiness in their thinking and attention problems, they can lose their way even on a yes-no question. So we recommend, and this comes from the field of speech-language pathology and use with patients post-stroke, we recommend tagging the end of the question with the response choices. Are you having pain? Yes or no? The main points are that older adults can have good outcomes from a critical illness. It's important to have a comprehensive assessment without assumptions that includes medication reconciliation. The second important point is to prevent and recognize delirium, facilitate communication and engagement throughout critical illness experience, and to mobilize and exercise patients early and often.
So that concludes our time with Dr. Mary Beth Happ, and I would like to thank her for sharing with us some of the skills and strategies that nurses will need in the intensive care unit when caring for older adults.